Good morning. Why did we perform this study? Yeah, simply, there were no studies, placebo-controlled outcome trials on statins when we started. But a lot of doctors took for granted that statins should work in everyone with coronary artery disease. In the first presentation here, you see that the study was done in 307 centers, mainly in Europe, but one other country, South Africa. And we included patients with systolic heart failure of ischemic etiology. Age should be 60 years or higher. In fact, the age range became 60 to 102 years with an average of 73 years. Ejection fraction should be 40% or less if they were in New York Heart Class 3 or 4. If they were in New York Heart Class 2, they should have 35% or less. The follow-up time became 2.7 years, and the patients were randomized to placebo or the statin Rosuvastatin 10 milligram, and we had 5,011 patients in the study, roughly 2,500 in each group. Yeah. We had a very marked effect on lipid lowering and also on inflammatory markers, and you see here the mean LDL at baseline was 3.5, and that was reduced by 45% and stayed reduced to that level during the whole follow-up of 36 months. This is a primary endpoint, and this was a composite endpoint of cardiovascular death or non-fatal myocardial infarction or non-fatal stroke. And we have assumed to get a 16% reduction in this primary endpoint, and we got an 8%. That means a hazard ratio of 0.92, and that was not significant. And in this post hoc analysis, you see we have a hazard ratio in favor of Rosuvastatin of 0.84. That means a 16% reduction, which was exactly what we had assumed to see. Another positive finding, too, that goes together with these observations in MI and stroke is that the total number of hospitalizations were significantly reduced. And that was mainly due, or all the effects were seen on the cardiovascular cause. So that was transmitted into a lower number of hospitalizations of all cause. Our interpretation of this study is that the primary endpoint was not reduced to the extent anticipated. We had assumed a 16% reduction, and we observed, as estimated from hazard ratio, only 8%. This estimated treatment, however, was very consistent across all subgroups. Favorable trends were seen with Rosuvastatin both for non-fatal myocardial infarction and non-fatal stroke. However, statin treatment had no effect on cardiovascular death, which accounted for the majority of the primary events. That was 68% of all. What can we learn from this study? Yeah, if we assume that Rosuvastatin did reduce the risk of acute atherothrombotic events, which we have seen from all other previous statin trials, our results suggest that the major etiology of cardiovascular death in this older vulnerable category of otherwise well-treated patients with advanced systolic heart failure may be a primary electrical event related more to ventricular dilatation and scarring and not to a new atherothrombotic event. Thank you.
There's a couple of very important messages here. We know that the life expectancy of advanced heart failure patients is relatively short. And you really can't protect those patients from dying of heart failure by giving them a statin. It's not a modifiable cause of death. What you can do is prevent them from having additional heart attacks or strokes. So many of us that were aware of this trial expected this kind of a result.
Dr. Gibbons, do you expect these findings to impact your clinical practice?
I do not. Like most American physicians, I try to follow the American Heart Association guidelines with respect to secondary prevention. So if a patient has coronary artery disease and a previous heart attack, I try to treat them to an LDL cholesterol target of 100 or less.
So, Dr. Gardner, would this change
I
your
think this was obviously a
treating heart failure
disappointing study
patients?
to the investigators. They had expected to see a beneficial effect. But this is a very difficult subset of patients. Heart failure patients are quite sick, and obviously the intention to treat here, or the purpose of the treatment with the statins, was to try to eliminate potential causes of premature or earlier death or sudden death from thrombotic atherosclerotic complications. So the negative result did not deter me, or I think most treating heart specialists.
Crystal Phend with MedPage Today. This question is for Dr. Yamerson. Going forward, what role do you see, if any, for the use of statins in heart failure patients?
If we assume that there are benefits also in some of the earlier placebo-controlled trial where they have not really reported separately the heart failure, but they have included patients with heart failure, and they have not at least reported any harm among those. So I think that all patients, even those with heart failure, will have about the same benefit, that you can influence the progression of their thromboatherosclerotic changes. But we think that in this study of all the very sick patients, you know, they were up to 102 years of age, and average was 73. They have scarring and dilated ventricles, and we think that more often there is a kind of electrical event and they get ventricular fibrillation or other electrical abnormalities that causes a death rather than a new occlusion. But, you know, we had the effect of the thromboatherosclerotic events, and we had a reduction of hospitalizations. So I think that the benefit we have seen in all the other studies, you can assume to see also in elderly patients. But I think the take-home message is that if you have a very sick person, let's say 85 to 90 years of age, and you expect that you might only have 1 to 2 more years to live, there is really no reason to put in a statin. But if a person is younger, or if the person has already been put on a statin and progresses into heart failure, the patients will tolerate the treatment, and you don't have to stop the medications since they go into heart failure.
So in patients who have significant problems with hepatic congestion, and they have fluctuations in their liver function tests, it may be difficult to monitor statins. Or in patients where cost is an issue, I will discontinue statins far sooner than I'll discontinue beta blockers or ACE inhibitors. And I think there are many physicians who follow that routine.
I think the negative result doesn't mean that the drug is harmful and shouldn't be used. I think that we still believe that theoretically, based on the event risks from thromboatherosclerotic problems, that a statin is indicated. And I think that's going to continue to be the general sense of cardiologists.
You know, most of the medical community has become very comfortable with the safety of statins. This was an entry-level dose. It was 10 milligrams of Rosuvastatin. I expected it to be safe, and it was. So I think you can look at this as either glass half full or half empty. I personally treat these patients with statins because I'd like to modify the heart attack and stroke events. I'd like to prevent those events if I can. But I don't expect they're going to live any longer because I've given them a statin. Look, what is our job? Our job is to both make people live longer, if we can, and live better if we can. Well, you don't live very well if you're in the hospital. And so I would consider prevention of hospitalization to be a tangible benefit for patients. And so if I have a therapy that will keep people out of the hospital and that's reasonably cost effective, then I'm going to use that therapy. The problem here is that that wasn't the primary endpoint of the trial. Now, do I think statins help these patients to stay out of the hospital? You bet. And taken in the context of everything else we know about statins, I think this is another piece of data to suggest that heart attacks can be prevented, strokes can be prevented, and some hospitalizations can be prevented. But taken alone, the trial doesn't give us that answer.